Hello and welcome to funwithpharmac.com and part 2 of the session on congestive heart failure. In part 1, we have seen what is congestive heart failure, what and where is the congestion in this patient, and what could lead to CHF and what are the consequences of CHF. We also saw the pathophysiology, what is going wrong in this patient which manifests as CHF. And the important thing to remember in this pathophysiology is that the basic problem with this heart is reduced force of contraction. And the very mechanism which is supposed to correct this situation for this heart, the sympathetic overactivity and renin-angiotensin-aldosterone mechanism, is making things worse for this heart, worse for this weak heart by making it run faster, increasing the heart rate and increasing both preload and afterload. Then what should be our strategy to help out this heart? Can we equate this heart to a gardener taking care of your garden? Gardener responsible for adequate watering and cleaning the garden. Like the heart is responsible for the mechanism which supplies nutrients to all our tissues and takes away the waste. So what if you have this big garden and this gardener, faithful gardener working for you, but he has become weak because of ill health? What would be your strategy to keep him working but yet not let your garden suffer? Obviously, you would think of giving him a tonic to recover his health, and in the meanwhile, you would like to reduce his workload. Maybe ask him to water one day and clean the other day. Whatever be your strategy. Same is the strategy employed in management of congestive heart failure. Management of this heart which has become weak. So the strategy can be explained or remembered as 3 Ds for congestive heart failure. The first D is digoxin, and it was the first drug which was introduced in management of congestive heart failure. What is this digoxin? It increases the force of contraction of the heart, and it does so without increasing the oxygen requirement. Like your motorcycle, the one which gives you more mileage for the same fuel would be called more efficient. Similarly, digoxin is said to increase the myocardial efficiency because it increases the output without increasing the oxygen consumption. Unlike some other drugs like adrenaline, which would also increase the oxygen consumption. So digoxin is a selective positive inotropic agent. Next comes diuretics, which can reduce the preload. We have seen that preload is the venous return which comes back to the heart and the heart has to pump out, or the end diastolic volume. So diuretics would reduce this end diastolic volume by reducing the blood volume itself. And the common diuretic chosen for chronic management of CHF is thiazide diuretic. Example, hydrochlorothiazide. We'll discuss why this choice a little later. Similarly, for other drugs used for reducing both preload and afterload are ACE inhibitors. Amongst the many available, why ACE inhibitors? ACE inhibitors can inhibit the formation of angiotensin II, and we have seen that angiotensin II is a very powerful vasoconstrictor, and thereby it increases both preload and afterload. Another component of action which contributes to increase in preload is release of aldosterone, which is causing sodium and water retention. So this facet of action of angiotensin II is also adding to the increase in preload. Another important facet of the action of aldosterone is that it causes remodeling. If you have understood remodeling, it is the reflex structural change, protective structural change, which the body brings about in some tissue in response to some chronic insult, which is, however, functionally detrimental. It doesn't help to improve the function. A common example to understand this concept would be a corn in your sole of your feet. What is the cause? Usually some prickly point in your footwear, which continuously causes irritation, and you're not changing the footwear. Then body has to do something about it. And what does the body do? It toughens this area where there is continuous pricking, and this is called the corn. But does development of corn help you to walk better? Definitely not, because it grows like a cone in your soul, and therefore corn itself will start pricking. So have you understood what is remodeling? It is a reflex, protective structural change brought about by the body in response to some chronic damaging influence which does not actually improve the function of that part. Similarly, this chronically overworked heart starts undergoing hypertrophy, and hypertrophy not only with muscles but with collagen tissue, which is making this heart bulkier but even less efficient, less effective, further compromising the force of contraction. And the culprit responsible for this remodeling is again aldosterone. So we have seen that AC inhibitors would contribute by 4 mechanisms in helping out this heart. They can reduce the preload, they can reduce the afterload. Preload reducing mechanism is venodilatation plus reduction in release of aldosterone, so less sodium and water retention. And the third thing is that it prevents remodeling. In fact, AC inhibitors have also been shown to reverse the remodeling which has occurred in these CHF patients. Before going ahead, we'll just try to clarify a little more about what is preload and afterload and how it can be reduced. Preload, as we said, is the venous return, and therefore venodilatation would reduce the venous return. It will increase the capacity of the veins to hold the blood. So venodilatation produced by AC inhibitors reduces the preload in addition to the reduction in aldosterone. And resistance vessels, if they are dilated, arterioles are dilated, it reduces the afterload. Another drug which was subsequently added to these 3Ds is carvedilol, and carvedilol is a beta blocker. Why the addition of beta blockers in management of CHF? Because it was found that anything which can cause sudden increase in sympathetic overactivity can lead to tachycardia and lead to worsening of the condition, sudden exacerbation of the CHF patients who are otherwise ambulatory. You know that sympathetic overactivity can be triggered by physical exertion, but once the patient gets a judgment of how much he can exert, he will do his daily routine within that limit. However, even emotional stress can suddenly trigger sympathetic overactivity, and this may not be voluntarily controllable. And therefore came the use of beta blockers in management of CHF to prevent these sudden exacerbations. If we block the beta-1 receptors, despite sympathetic overactivity, heart rate will not increase and therefore things will not become bad. Subsequently, the role of beta blockers which was realized, additional role was realized, was that continuous sympathetic overactivity can cause further deterioration by increasing the rate of apoptosis of the cardiomyocytes. That is, the heart muscle cells start dying faster. And beta blockers can also protect the heart from this chronic influence which is leading to progression of the disease. So now carvedilol is referred to as a disease modifying agent, trying to slow down the progression of the disease, and for which the contributing effects are, it is not just a beta blocker preventing tachycardia and preventing this increase in apoptosis, it is also an alpha blocker. So it can also cause vasodilatation, reducing both preload and afterload. In addition, it has antioxidant activity. And in all these chronic conditions, today, oxidative stress has been implicated. And therefore, antioxidant activity is supposed to be beneficial. The other drugs which are also called as disease modifying agents are the AC inhibitors. Why? Because they are preventing the remodeling, which is also contributing to worsening of the condition. So in management, chronic management of CHF, we have digoxin to improve the force of contraction without increasing oxygen consumption, without causing tachycardia. Selective positive inotropic agent. We have diuretics, the moderate acting diuretics, thiazide diuretics, which can cause reduction in blood volume and thereby reduce the venous return, that is, control the preload. And we have the vasodilators, AC inhibitors, which work by reducing the production of angiotensin II, which is a very powerful vasoconstrictor. Thereby, they reduce preload by causing venodilatation. They reduce afterload by causing arteriolar dilatation. The other important action of angiotensin II, which is also not happening, is release of aldosterone, and therefore sodium water retention is reduced. That will also contribute to reduction of preload. And the fourth important action is preventing and even reversing remodeling, which is responsible for progression of the disease. And the fourth drug is carvedilol, an alpha-beta blocker with antioxidant activity, which is able to prevent the adverse influence of sympathetic overactivity. Sudden increase leading to sudden exacerbation as well as increased apoptosis is prevented, which can be useful for slowing down the progression of the disease. So these are the drugs used in management of chronic management of congestive heart failure so that the patient doesn't worsen into acute situations. The acute situation of congestive heart failure is called the acute LVF, and this acute LVF is also managed on the same lines. Only the drugs would be changed because you want to handle the acute situation urgently. So instead of digoxin, we shift to intravenous dobutamine, which is also a selective positive inotropic agent. Digoxin may continue, but because it is slow acting, we cannot rely on it for handling an acute situation. The diuretic chosen is furosemide instead of thiazides, again because it is a quicker acting and more effective diuretic, but that's not the only reason. Furosemide has another action, which is vasodilatation, direct vasodilator effect, which is more in systemic circulation than in the pulmonary. And therefore, furosemide is able to shift fluid from lungs into systemic circulation. This is effectively, it is reduction in pulmonary congestion. And this dramatic reduction in pulmonary congestion occurs within 15 minutes, 1-5, of oral furosemide, whereas diuretic action takes 20 minutes. And this important shift of fluid from pulmonary to systemic, dramatically relieving pulmonary congestion, has secondary benefits as well of reducing the anxiety, thereby bringing down the sympathetic overactivity. And the dilators which are used in acute LVF are GTN or, if required, sodium nitroprusside. GTN, which can reduce only preload because it is predominantly venodilator, and sodium nitroprusside, which can reduce both preload and afterload because it dilates both veins and arterioles. Two more drugs which are required in this situation are morphine, which is not as an analgesic because there is no pain in acute LVF. But morphine also has the same vascular effects as furosemide. So it can also shift fluid from lungs to systemic circulation and relieve pulmonary congestion. This would reduce patient's anxiety, and morphine in addition has got its own anxiolytic action. So both these actions of morphine are important. And the fourth agent in acute LVF is obviously oxygen. So these are the drugs for treatment of CHF and acute LVF. The drugs to relieve low output or congestive symptoms are selective positive inotropic agents, digoxin in chronic management, dobutamine, and if not, then dopamine for acute management. Diuretics, thiazide for chronic management, furosemide for acute LVF. Vasodilators, enalapril for chronic management, an AC inhibitor, and GTN or sodium nitroprusside for acute management. To arrest the progression of the disease modifying agents in chronic management are AC inhibitors themselves, or spironolactone is another agent which has these actions, but more commonly used are AC inhibitors and beta blockers. And instead of beta blockers, we use alpha and beta blocker carvedilol. And the two drugs added for acute management are morphine and oxygen. So this is the drug armamentarium on which management of CHF rests. In the next session, we will go to see the details of these drugs and understand in more detail how they help a patient of CHF. Thank you. If you found this useful, if you like it, please do express your like and